You know that nagging, persistent pain? Right on that bony bump on the inside of your elbow? Yeah, you're not alone. It's a super common complaint. But what's really going on under the skin? Well, that's often a bit of a medical mystery. So today, we're going to put on our detective hats. So, what's the first thing that pops into your head? For most people, it's golfer's elbow, right? It's the name we all know. But what if that common label is actually, hiding the real problem?
Because you see, for a lot of people, especially athletes and folks who work with their hands, the problem can run a whole lot deeper than just a simple tendon issue. That pain you're feeling, it could actually be a sign of a ligament tear, a pinched nerve, or maybe something else entirely. All right, so let's investigate. We're going to follow the clues, look at the evidence, and really decode what that pain on the inside of your elbow is trying to tell you.
Okay, so our investigation kicks off with a really fundamental idea. That pain you're feeling, it's not the diagnosis. Think of it more like an alarm bell going off. It's just a symptom that's telling us, hey, something's wrong here. Our job is to figure out what's actually triggering it.
And let's start with a fact that might actually surprise you. For all the talk about it, true golfer's elbow, the medical term is medial epicondylitis, is actually pretty rare. I mean, look at this. It affects less than 1% of the population. To put that in perspective, that's way less common than tennis elbow. So this is our first big clue. If you have this pain, the odds are pretty high that it's not what you think it is.
So, if it's not affecting most people, then who is getting it? Well, this brings us to our lineup of usual suspects. All the clues point to people whose jobs or hobbies put a very specific, repetitive kind of strain on that inner elbow. So, let's take a look. And when you look at who's most at risk, a really clear pattern starts to emerge. It all boils down to these forceful, repetitive movements. We're talking about bending your wrist down and turning your palm to face the floor, over and over and over again. You see it right there. Baseball pitchers, carpenters with a hammer, plumbers turning a wrench, even just workers who have to lift heavy objects all day. All of these things put a ton of stress on that one tiny spot.
Now, to really get why throwers are so at risk, you got to appreciate the physics involved. And this number, wow, it puts it all in perspective. See, the ligaments in your elbow can handle about 260 newtons of force before they give out. But a professional pitcher, they can generate 300 newtons of force on that joint in a single throw. Think about that. They are literally pushing their elbow past its structural limits with every single pitch. That's why these athletes are just in a completely different category.
Okay, so we've got our at-risk group, and we understand the insane forces at play. So, how does a doctor actually crack the case? Well, a good diagnosis is really a process of elimination. It's all about following the clues from your own story, your activities, and a few key physical tests to zero in on the real culprit.
All right, suspect number one is the one we all know, medial epicondylitis, aka golfer's elbow. Now, the key thing to get here is that this is not just simple inflammation. The best way to think about it is like a rope that's slowly fraying from being used too much. The fancy medical term is angiofibroblastic tendinosis, which I know sounds complicated, but it just means that tiny little tears in the tendon aren't healing right, and so the tissue starts to break down and get weaker.
So, how do you actually test for this frayed rope condition? Well, one of the classic tests a doctor will do is called resisted wrist flexion. You can see it happening right here. The doctor has the patient try to bend their wrist forward while they gently push back. If doing that brings on that sharp, familiar pain right on the inner elbow, well, that's a really strong clue pointing straight at medial epicondylitis. But remember that 300 newtons of force we talked about? For a pitcher, or really any overhead athlete, that constant, high-power motion means the investigation often has to look somewhere else. The problem is frequently much deeper than just the tendon. And in these cases, the main suspect becomes the medial collateral ligament, or the MCL. This thing is the key stabilizer on the inside of your elbow. It's your number one defense against those crazy outward forces from throwing. And unlike the tendon, which frays over time, this is more of a structural failure. We're talking about the ligament itself getting strained or even torn because it's been stretched past its breaking point over and over. Now, because we're talking about a deeper structural problem, a simple physical exam might not tell the whole story. And that's where imaging, like an MRI, becomes so important. What you're looking at here is an MRI that clearly shows a partial tear of that MCL. You see that bright white signal the arrow is pointing to? That's fluid. That's damage inside the ligament. It's the definitive proof the doctors need to see that the main stabilizer has been compromised. But hold on, there's a third major suspect we need to consider, the ulnar nerve. You probably know it as the funny bone nerve.
And this is where things can get a little tricky, because nerve pain can feel a lot like tendon pain. The real giveaway, the big difference, is how the pain acts. Tendon pain flares up when you use the muscle, right? Like that wrist flexion test. But nerve pain, what's called neuritis, that often gets worse with direct pressure, like if a doctor taps on the nerve. And it usually comes with those telltale signs like tingling or numbness in your ring and pinky finger. So, once all the detective work is done and the real culprit has been identified, it's time to talk about the solution. And the good news is, there's a pretty clear playbook for treatment. It always starts with the most conservative steps and only moves on if it absolutely has to. Let's walk through it. Okay, so the first line of defense is pretty much always the conservative route. And it starts with what sounds like the most obvious advice in the world. You gotta stop doing the thing that's causing the pain. From there, it's about managing the symptoms with things like ice and maybe some oral analgesics, and then, crucially, starting physical therapy to strengthen and stretch everything out. And here's the best part. For classic golfer's elbow, this approach works for about 9 out of 10 people. That's a fantastic success rate.
But what about that other 10%? The ones with that stubborn pain that just won't quit? Well, for them, surgery becomes a real option. And the procedure itself is actually pretty logical when you break it down. As you can see in this diagram, the surgeon goes in and first cleans out all that damaged, frayed tissue. Then they put a tiny little anchor into the bone, and finally they reattach the healthy part of the tendon right to that anchor. The whole point is to create a brand new, solid connection.
So, does it work? Well, the data's pretty clear. Yes, it's highly effective. Just look at these studies. The success rates for good or excellent results are consistently way up there. We're talking 85 to 90%, even higher in some cases. This is really reassuring because it means that even if the conservative approach doesn't work out, there's still a very reliable backup plan. Now, there's one more group we absolutely have to talk about because they're in a special and kind of vulnerable position, and that's young athletes. For kids and teens whose bodies are still growing, that repetitive stress from throwing can cause a whole unique set of problems in an elbow that's not even fully developed yet. You've probably heard the term Little League elbow, right? Well, it's not actually one single injury. It's more of an umbrella term that covers a whole range of overuse issues in young throwers. See, because their bones are still growing, the weakest spot in the joint is often the growth plate, that little area of cartilage where new bone forms. And the incredible pulling force from throwing can either just inflame that growth plate or, in the worst case scenario, actually fracture it and pull it right off the bone. And this is what that looks like. It's pretty dramatic. On the left, that's an X-ray of a young athlete where the medial epicondyle, that main bony bump on the inside, has been completely ripped away from the arm bone by the force of throwing. That is a serious injury, and it requires surgery to fix. Then, on the right, you see the aftershot, where that piece of bone has been reattached with a screw. It's just a really stark visual reminder of the unique risks these young athletes face.
Okay, so after all that investigation, what's the bottom line? What are the key things to remember? First, that pain on the inside of your elbow isn't a diagnosis, it's a clue. The real culprit could be a tendon, a ligament, or a nerve. Second, because of that, getting the right diagnosis is absolutely everything. And finally, while the treatments are great, we have to be extra careful with overhead throwers, and especially young athletes who face their own unique set of risks.
And that really just leaves us with one final thought. Our bodies are sending us signals all the time. That pain in your elbow isn't random. It's part of a much bigger story about the stress and strain of how you move, how you work, and how you play. So the real question to ask yourself is, are you listening to what your body is trying to tell you?